It's June 7, 2024. I'm Jack Cush with Room Now, and it's 5 days away from EULAR. I'm getting ready. Are you? More about our coverage of EULAR 2024 at the end. Let's begin with a regulatory announcement this week. The FDA gave another indication to upadacitinib, this time for use in pediatric forms of aggressive inflammatory arthritis. That includes active polyarticular JIA and also juvenile psoriatic arthritis. This is for children above the age of 2. The approval is based on well-done studies. The indication is for those two conditions in those who have had an inadequate response or intolerance to a TNF inhibitor. The other thing that's important is that it's also available as an oral solution, which could be helpful in kids, could be helpful in some adults, don't you think? I don't know if you saw this report in JAMA a few days ago about an increasing risk of tick-borne disease. I put that out as a tweet. And I looked at the numbers. They quote, of course, the most common tick-borne disease is that of Lyme arthritis. And they quote numbers, I want to say like 300,000-400,000 cases a year. I got to say, they go through a tremendous number of tick-borne diseases, many of whom I've never really seen. And I got to say, as much as we talk about tick-borne disease, rickettsial disease in, teaching and whatnot, it's rare. I think we need to know about it for the tests. But I got to tell you, the number of cases, I've seen one Rocky Mountain spotted fever in my whole career. I've probably seen, now I'm not in an endemic area for Lyme, right? That's the Northeast and certain pockets of the country. But you'll find reports of Lyme disease all over the country, and it's based on largely inaccurate serologic testing in low-risk individuals. Wake up. So my point is that these are still rare, and that I don't know that they should be marquee disorders. I'd like to learn something from them, and I don't know that we've learned very much about, and Alan Steer will probably hit me on the head for saying this, that we haven't used what we've learned about Lyme disease to apply to other disorders to make us smarter in managing either inflammatory arthritis that's reactive, infectious, or otherwise. This study about psoriatic arthritis and aortic stiffness, I thought that was important this week because we do know that psoriatic patients, both skin and joints, have a higher degree of cardiovascular comorbidity. This particular study of 150 patients looked at carotid femoral pulse wave velocity, showing that it was significantly higher in PSA patients than controls, and that these high elevations of pulse wave velocities were seen in those with longer disease durations, systolic hypertension, GFR alterations, RDW, a marker of inflammation and cardiovascular disease, and it was superior to the usual methods of assessing cardiovascular risk, including the SCORE. So again, this sort of supported data about the cardiovascular risks. I don't know that we need to do pulse wave velocity on all of our patients, but it wouldn't be a bad idea to have a worry about coronary artery disease and vascular disease in these patients. An Israeli study looked at the prevalence of psoriatic arthritis in their population and showing since 2006 to 2022, the prevalence in the population grew to 0.07%. So that would be 7.3 cases per 1,000. And then it's grown to 220. No, that would be 22 cases per 1,000. 22 cases? Yeah. Anyway, 0.221%. There was a twofold increased risk if you were Jewish. It's an Israeli population. But you come from higher socioeconomic groups and with obesity. So is psoriatic arthritis following the pattern of gout, wherein it looks like the obesity epidemic and our nutritional indiscretions have contributed significantly to the prevalence of arthritis, in this case psoriatic arthritis. A full read review on psoriasis flares and I listed them for you. I think it's reviewing here. Mechanical stress. We've always known that physical activity, mechanical stress was a risk factor, but also infections, dysbiosis, drugs, lithium, beta blockers, hydroxychloroquine, tetracyclines, ACE inhibitors, and the interferons. A few of those I didn't know. Must say I've lived a long, long time and have yet to see a significant flare of psoriasis with hydroxychloroquine use or with the withdrawal of steroids. Now, I can be faulted for being a garden variety rheumatologist who doesn't see a ton of psoriasis, but I got hundreds of psoriatic arthritis patients over many, many years. I'd expect a bigger signal in my own observations, but I got to believe the literature on that. Environment, smoking, obesity, we know other lifestyle things, stress, and hormonal factors are risk factors for flares of psoriasis. A study from China looked at the incidence of ANCA-associated vasculitis patients, the incidence of cancer in those patients. Don't see much data on this. They had a cohort of 550 patients. 23 had cancer prior to or with the onset of the ANCA-associated vasculitis, and 43 had cancer diagnosed in the 4.3 median years of follow-up afterwards. This was an increased rate. The standardized incidence ratio, which is a comparison to a normal population, showed a twofold higher risk. The cancers that were most in play was lung cancer with a fivefold higher risk. Also, other cancers increase in ANCA-associated vasculitis would be kidney, bladder, ureter. That's a holdover from all that old cyclophosphamide data. You wonder how those people were treated. But also prostate. Is there a genitourinary predilection that is independent of cyclophosphamide? I don't know. Higher risk if you were male, 2.8, or with each year goes up 4% that you're older, over 65 or 60, I think it was. Another interesting study of myositis patients looked at the findings of multiple myositis-specific antibodies amongst a cohort of 200 plus patients with idiopathic inflammatory myositis. They found 22% that had multiple myositis-specific antibodies. 2/3 of them were the tRNA synthetase, the Jo-1 like antibodies, and in this population, half of those, I guess, also were MDA5 positive. So MSA, but interestingly, multiple myositis-specific antibodies had a better survival, had less rapidly progressive ILD, had more fever, rash, and more muscle and dysphagia presentations. It seemed like it predisposed to a milder set of conditions. And maybe it is worth doing a battery of tests and seeing that this proves true. In lupus, what happens when you have multiple autoantibodies? Certainly, lupus gets lots of multiple autoantibodies, but I learned from Morris Reichland and others that certain patterns of involvement, like Rho, SM, and double-stranded DNA, boy, that's a bad pattern to have. So this is interesting, and it's the converse. Maybe a better outcome for those with multiple myositis-specific antibodies. Scleroderma in the news, where we have this very odd, very rare variant of scleroderma or systemic sclerosis sine scleroderma, meaning that they have either GI, lung, cardiac, Raynaud's, but not sclerodactyly and thickening of skin. Seen in kids and adults, and the report that they have is just a cohort analysis of 18 kids versus 38 adults. Those who had the juvenile form were more likely to be female. They had more digital pitting scars and ulcers. They had more pulmonary involvement and more cardiovascular involvement. They also had more deaths. So, not surprisingly, kids developing an aggressive autoimmune disease may have a worse outcome than their adult counterparts. We certainly see this in lupus. Maybe it takes a lot genetically, pathogenetically, to get the disorder at such a young age that you're going to be predestined for more aggressive disease. A post hoc analysis of ankylosing spondylitis patients treated with tofacitinib looked at how quickly they respond. I thought this is interesting because it harkens back to my earliest introduction to tofacitinib. And that was, I was invited to a review of the data. And they presented data. This was like I don't know, I can't remember where it was. But they presented the data on like a 250 patient trial where the primary endpoint was 6 weeks. And that's all they had data for. And I said, what are these knuckleheads doing? They're doing an RA trial with a new drug and they got 6-week endpoints? How stupid is this? Well, then they showed us the data and boom, they had impressive data with good responses by 6 weeks. They didn't need 12, 14, 16, or 24 weeks to show what were going to be maximal responses. Anyway, we now know that JAK inhibitors work quickly, right? I think the half-life on tofa is 3 hours. On the long-acting tofa, I think it's 6 to 8 hours. In this study, ankylosing spondylitis patients, a post-hoc analysis, 269 patients, greater than 30% improvement in pain was achieved in 4 weeks. 4 weeks it took to improve the ASDAS by more than 1.1 points. It took a range of 8 to 24 weeks to get 50% or more improvement in overall pain, enthesitis, stiffness, and BASDAI and fatigue scores. The point is that pain responds quickly. And in inflammatory arthritis, that can respond 2 to 4 weeks as well. Anyway, this is sort of an objective assessment of how quickly they respond. An analysis of what the cost of care is. We don't see much of this, but it comes out of Australia, looking at informal, meaning usually like family members, who are caregivers of those who have chronic arthritis. These are informal caregivers who are not currently working. And when they did the analysis, they showed in 2015 the excess costs incurred by these informal caregivers or arthritis patient was almost $400 million. And they projected that to increase to $576 million by 2030. And the problem is, of course, informal caregivers are unable or are less likely to work given the demands of their duties in taking care of arthritis patients. This needs to be accounted for in our public health measures to better manage patients with arthritis. There are a lot of solutions here, but I'll leave it up to the legislators and those of you who are active in lobbying legislators to have this discussion. A Canadian study of older adults with gout, and this is like a very large 44,000 patient study. These are not rheumatologist cared for gout patients. Only 3.5% are taken care of by rheumatologists. But this older adult, 76 years of age, or was their median, only 52% achieved a serum uric acid within 12 months. That's less than 6. This improved from 2010 to 2019 from 45 to 61%, as did urate-lowering drug therapy, but that was still also low, only 55%. Gout is gigantically untreated, especially in the real world, the non-rheumatologist world. We're much better, but even we have some faults. Another study out of Canada showed the disconnected care of patients who have new joint complaints. 82 patients who were surveyed, only 29% of them went to the emergency room. For a third of those, that was a repeat visit for their arthritis flare. Only 26% of those that were seen were referred to a rheumatologist. And then the patients themselves, only about a third of them were able to see the rheumatologist in the time frame suggested. There's a lot of fault going on here, right? And I think the fault should sort of begin with us. We're the experts. We should be advertising. This is what I want to see. This is when I'll see it. This is the pathway to get an acute arthritis or a new vasculitis or a new RA patient in. And then you'll be surprised, but most of us don't do this. So anyway, another gout report this week we did put up did show that plant-based diets in gout are very, very effective at reducing the incidence of gout. Another important diet article came out this week in JAMA about 25,000 plus women followed for 25 years, showed that the adherence to a Mediterranean diet lowered all-cause mortality by 23%. That risk reduction in mortality was mostly explained by changes in lipids, inflammation markers, and BMI, not at all by cholesterol numbers or other glycemic measures. Really interesting. MedPage Today published an article this week that we co-published about the Perfecta trial. Which is better, right? After you fail a conventional DMARD, should you use a TNF inhibitor or a JAK inhibitor? So this is a 200-patient real-world study, open label, where patients were either given any one of the 3 TNF inhibitors or baricitinib in standard doses. This is an open-label, non-inferiority trial with a 48-week endpoint. And to my surprise, baricitinib was not just non-inferior, it was superior by ACR 50 at week 12 and also at week 48. At week 12, it was 42% versus 20%. Moreover, the DAS remission numbers were achieved by 75% as well. And then the time on baricitinib was longer than on a TNF inhibitor. I think 2/3 of the TNF inhibitor use was adalimumab in this study. This study, is it real? I mean, is a JAK inhibitor better than a TNF inhibitor in a biologic JAK inhibitor naive RA population? We don't see many studies like that. This study can be faulted by being open label, and there are certainly biases with both patient and physician. It was also real world, meaning that they didn't have a lot of exclusions, that the inclusion was pretty simple. But this is getting down the pathway of what the FDA is looking more and more at, which are real world data trials and what they call pragmatic clinical trials. They're not going to replace the double-blind randomized placebo-controlled trial, but they may take an important role in future drug approvals, especially for a drug that's initially been approved, and that might be for secondary indications. I have a last report about cannabis. JAMA had a few articles this week about cannabis, that it being pretty common. Gelber and colleagues from an Los Angeles cohort looked at a cross-sectional study of 175,000 patients, of whom 17% were using cannabis. In the last 3 months, 35% were taking it because of moderate to high, that they were claiming that they were high risk. And I think that meant that they were taking it for higher levels of pain. 3/4 of the patients said that they were using cannabis for a health symptom management, but only, that's 75%, only 16% identified this as medical cannabis use. There's a lot of self-diagnosis going on. Cannabis was being used to manage pain, 32%, stress, 50%, and sleep, 56%. It was higher amongst males, higher amongst the youth, and it was mostly in the form of edibles and smoking. So the bottom line is, it's common, and you need to know about it. Your patients don't tell you about their supplemental products and nutraceutical use, vitamins, etc. They're probably not going to tell you about cannabis unless you ask. Point is, you should ask. The second report coming out of the United Kingdom looked at 121,000 patients, and they assessed cardiovascular mortality, and they basically showed that heavy users of cannabis that were women were more likely to have an increased risk of cardiovascular mortality, a 2.67 hazard ratio. This was not seen in men. By the way, that in other cancers, all-cause mortality and cancer mortality, all other forms of mortality, all-cause and cancer was not increased with cannabis use, but cardiovascular was. And that's kind of surprising. I also just put up another tweet for next week from a large cardiology study which showed that cannabis was associated with higher levels of or higher risks of arrhythmias. So here we go. New onset arrhythmia, a twofold higher risk, but not a higher risk of coronary artery syndrome. The point is that we need to know about cannabis, that we need to recognize cannabis may not be safe in all. We need more research about cannabis going forward. That's it for this week on the podcast. Hope you enjoyed it. Be sure to follow us next week. Our coverage of EULAR begins on the 12th, and it's going to go all the way through like the 21st, the following week. The 12th is Wednesday, the first day. We got the Room Now reporters. We got a bunch of KOLs. We got a lot of interviews and written articles, tons of tweets. Watch for us. We're going to be doing daily recaps at the end of every day starting Thursday. I believe those are going to appear around noon as a live stream and a live broadcast from where I'm going to be at the meeting in Vienna with my colleagues. When we get back, we'll be doing topic podcasts that will go at, I believe, 5 p.m. Eastern time every day, Monday, Tuesday, Wednesday, Thursday, starting the week after EULAR, which I think the date on that is the 17th through the 20th of June. Tune in. You can watch these at your leisure, on demand. We got tons of videos, lots of learning from EULAR. I think you're going to enjoy it. I know I am. We'll see you at EULAR.